Our next speaker is Katie Ives, a Senior Program Officer at the BlueCross and BlueShield of North Carolina Foundation. She joins us today to share their collaborative efforts to support upstream and community-centered approaches to improving health, and we're so glad that she's with us today. Katie?
Thanks very much, and I will have you advance my slides for me as we go along, so I'll let you know. I think this is a good grounding, certainly, and I like this language that Dr. Thorpe used around community-based determinants of health. I think that's the approach that we're grounding our work in, the understanding that the social risk factors are sort of undergirded by systems that increase or decrease opportunity to be healthy at the population level. And so our work truly happens at the population level versus the individual level. And this is but one approach. We call it community-centered health, of how primary care or healthcare generally engages to work with and in many senses be led by community to increase opportunity for good health for all. So now I'm going to move on to the slide number 2. So a little bit about us before I start. The BlueCross BlueShield Foundation was established in 2000. We've made about 1,000 grants totaling $131 million, and we historically funded in 3 core areas. I say that because it becomes relevant to my points today as I talk a little bit about the impact that funding this work and being on the periphery of it as it has occurred in communities we've funded, the impact that has had on us as a funder in terms of really changing our approach. On the next slide, community-centered health, again, is what we're calling it, and the subject of the webinar today is what's being done to eliminate barriers to being healthy. Our approach in a nutshell has been to ask those individuals who experience disparities or who are familiar with the environmental conditions that lead to inequity to prioritize, and by that I mean to set the agenda for the work of clinical community partnerships to reduce those barriers. And sometimes we talk about it in the language more so of opportunity. We say reduce barriers and create greater opportunity to be healthy. We embarked on this in 2014, and in some ways it feels like yesterday, but again, it has been transformational to our approach, so much so that we've reframed our strategy based on learning over the last 4 years. In the next slide, the philosophy of this is sort of the general approach we take. And in some ways, it's better to understand what this is not about. It's not about finding and implementing evidence-based programs, and it's generally not about access to care, although it can certainly have that impact. Related to that, I've sort of previewed, it's also not about individuals, but more so about communities and building partnerships to have that impact at the population level. And therefore about seeking and achieving systems level changes that have that impact at the population level. On the next slide, the core components, this is sort of what we understand as 3 core pieces. Community-centered health as we understand it is not a model, it's really an evolving framework that we understand in new ways on a daily basis sometimes as we learn from our grantees and others doing similar work around the country. And while it has many variations, we do think of these 3 components. So the first is that they're clinical community partnerships in which community members themselves are recognized for wisdom and expertise on the conditions that cause poor health and have leadership roles. And the community involvement goes beyond focus groups or general participation to really having community members contribute to the shared understanding of those conditions and play a key role in identifying priorities for action. And to implement that in primary care, what we see is many practices start by asking different questions, like what are your health goals, what are the barriers or what's in the way to achieving them. Looking again at that individual experience more so than evidence. And that's the beginning of this second piece, which is called clinical shift. And what we mean by that is that healthcare organizations make changes in their own processes or culture to the ways they partner or share data with community to both identify and act on those non-medical barriers to good health. That has impacts at the community level, of course, but what we're also seeing is that it impacts patient experience. It does mean that there are very different activities. And in my opening slide, you saw a physician, and that's Dr. Mulberry of Greensboro, and she recently appeared at the city's Minimum Housing Standards Board. So it really does ask in that clinical shift piece for providers and healthcare organizations to really act differently, in this case as advocates. And in some ways, some of the things it's asking are unnatural for healthcare as it has evolved. And then finally, the key piece is that this is really working at the policy and systems change level with a very broad reach. And we believe that that is what sustains impact over the long term and leads to those long-term improvements. On the next slide, just some really technical elements, crosswalking data being a piece of that. The data piece is something that healthcare has a great deal of data, but it's not always informed by the conditions in the community. So crosswalking clinical and community data is a technical approach that is having an impact in these partnerships. And then again, as I mentioned, acting through advocacy as another approach that particularly healthcare organizations and their community partners can undertake. On the next slide, I just really want to mention that this does fit into sort of an emerging theme that we see in healthcare and in the approach to health across the country. And that's that health is not a product of healthcare in its historical sense. That healthcare can play a substantial role in improving health by shifting the gaze upstream of the immediate health crisis while tending to it. And so it does ask to really think about health differently from that healthcare perspective. On the next slide, the grantees we have now are in 3 communities. I'll talk about each of them. We're in the process of identifying a second cohort of likely 7, but I'll go into each of them in detail on the next slide, starting with Healthier Highland. And you see on the slide some of the work they're doing. This is rooted in a community health center. The health center staff is working closely, though, with city planners. And as a result, they've generated in the last couple of years $2 million in infrastructure investments in the community. So those are a direct result of advocacy by primary care, health center staff, advocacy with the planning department to get more sidewalks, crosswalks, housing, splash park, and public bathrooms in a city park. They're also working, again, through the health center as the hub in increasing community representation in some of the civic processes in town. So they have a goal of getting 5 local residents on city and county advisory boards. This is a key strategy that many of the sites we're working with are using, is getting, again, those people who personally understand the factors that are barriers to health, informing planning, parks, transportation in their localities. And that growing understanding of local data and where inequities exist, using that to influence decision-making really has been one of the keys to impact, because I think we find that everyone wants to do the right thing there, and the data can help us understand what that right thing might be. Many of our partners have engaged community health workers. At this site, they've hired a community health worker who was a former worker in their local cafeteria. And she lives in the community and is supporting them to engage on school food. So she brings an expertise on school food. She brings the relationship she has from walking daily in the community, and as a community health worker brings a unique lens to them, both in terms of systems as well as the individual's patient. They're a pilot site for an enhanced benefit for our SNAP program that brings $40 in fresh fruits and vegetables. And so you can see by that sort of mix of things, they really have a mix of both programs and system strategies that engage residents and can lead to lasting change. On the next slide, we have Collaborative Cottage Grove, and that's in the Greensboro community. Their focus has really been on housing, and rather than being in the health center directly, the grantee there is the Housing Coalition, but they're in deep partnership with both a free clinic and the hospital system. So a focus on both primary care environment and emergency department utilization. Everyone understands that this community was an asthma hotspot. Digging into the data from code enforcement showed that the asthma exacerbations were caused by infestations and water intrusions. And the conditions were so bad that there's a 170-unit apartment complex there, and these are not subsidized units. These are units that people were paying a low rate but a market rate for, and because they were affordable to them, but they were really having an impact, obviously, on their health. And so this partnership of hospital, primary care, and housing advocates advocated with the owner and led to the sale of the complex to a new owner who's committed to bringing up the standard of housing while keeping rents as low as possible. They've done efficiency upgrades with city dollars that will lower utility costs, and so rents will go up, but they think the overall cost is going to remain about on par with what it was before because of those efficiencies on utilities. And so we see this unique partnership coming together to really improve health through housing condition improvements in the community. They've also worked with community health workers, neighborhood associations. They have strong linkages to university programs where they're acting as a training ground for a variety of health services, professionals in the universities. They're using students using Google Street View to assess housing conditions in the community, that they can look at the conditions of the gutters and the paint and use that data to sort of inform some of their hotspotting work. They have linkages to planning and transportation departments. So again, a really complex partnership, but at the heart of it is healthcare. And ultimately, the hospital system there is changed its approach and its policies around data sharing to make its data more accessible to community partners. And they're also changed their mission statement, not a direct result of this work certainly, but with a much stronger orientation to prevention. And we think that's based on the experience. The last example on the next slide is Mothering Asheville, and that's not as much about chronic disease, but again, a partnership that is working on a disparity. They have Black babies dying at 3 times the rate of white babies in their community. Again, they're using community health workers and doulas, and they've developed a doula program that means new jobs for women in the community, and it's being systematized by integrating referral and workflows into their healthcare system. I bring this one up also because they're using legal aid as a partner, and they've embedded legal aid in the OB practice. That's certainly something that can be done in primary care and the medical legal partnership program, because frequently barriers to health at the individual level can be caused by issues such as housing, interpersonal violence, benefits, securing benefits. And many of those issues have a legal remedy. So legal aid has been a key partner in North Carolina on this work as well. I'll bring us next to our 2.0 work. So we have 4 years of experience that we're building on and lessons building on. And so we're embarking on new relationships with grantees. And in the next slide, sort of covering, we issued an RFP for what we call Community Health 2.0, and we received 170 letters of interest based on that. That is the highest number of submissions we've ever received for a grant cycle. So it is clear that there is appetite for this work, and most of those partnerships had healthcare as an active partner at the table already. These communities, of course, exist on a continuum of readiness and interest and commitment to these and similar approaches. And I'll say this is but one approach to support work that acknowledges and acts on these community drivers of health. And it's not the only one we as an organization use, but we believe that this approach will only grow in sort of the level of interest that is out there, as well as the capacity. And we are committed to supporting that capacity. To that end, on the next slide, I want to emphasize this sort of chart shows the types of non-medical barriers that those 170 applicants expressed to us they wanted to address. And so you see healthcare is on there at some level, but more so, the size of those words and the word cloud point to the how frequently they were mentioned by our applicants. So housing, food, environment, ACEs, trauma, these pieces are all resonating with communities and healthcare and community partnerships that they want to address. And when we're talking about chronic conditions, there are, of course, many non-medical drivers represented here that communities have a desire to work on. In the next section, I will just briefly mention some of our learning that we have embarked on or we have inherited, I guess, in partnership with our grantees. On the first slide here is capacity. So while this work seems sort of natural and logical when it's explained, it's actually really unnatural, we found, for folks to partner in this way. Going back to its most basic, the essentials of partnership is even language. When we say residents to primary care, they think of something very specific. They think of medical residents. When you say residents to community partners, they think of people who live in the community. Likewise, when we say population health, what do we mean exactly? Public health and primary health have very different definitions of some of this terminology and expectations of the work, and community is a whole nother stakeholder to consider their definitions and priorities. So we have supported a great deal of capacity buildings in all the communities we're working in. This means leadership, it means facilitative skill set. In many ways, capacity starts with being able to explain the approach, a community being able to recruit somebody, a new partner, because they can explain the work and the return on investment. There's also technical and adaptive work that needs to occur in terms of that data sharing piece, power dynamics, equity and inclusion come up as very important capacities at the community and institution level. And as I said earlier, this has great relevance to patient experience and to some of the technical skills of healthcare, how docs engage with patients, what team-based care looks like, who's on the team and how the team works together, operations and workflow, certainly patient feedback loops. And finally, I'll say equity again. I think being able to have conversations about race and the effects of racism and other systemic oppression becomes key to progress over time in these communities. And so seeing both oppression and its impact over decades on health becomes very important to being able to address the effects of that through systems. And we're being very intentional about making sure our 2.0 cohort has support to elevate equity and the health impacts of inequities at the beginning of their work. On the next slide, I'll talk briefly about sustainability, which I know is key, and I'm sure some are thinking, like, how would we possibly pay for this without private funding? And I will acknowledge that sustainability remains elusive, but we have hope. There are not easy answers, and that's in some ways because the data is siloed in different places and must be looked at and shared in new ways. This also sort of makes the ROI calculation very different than most stakeholders are accustomed to looking at. What is the timeline to ROI? Where are you looking to incur your savings? So addressing neighborhood safety, for example, has implications on health, we think, but also on many other budget lines in our communities and social systems. And so we are really partnering with our grantees to look beyond the usual time horizons to ROI and also the usual payers that we think about when we think about health. And so one of the work that we're asking our grantees to do is to have that conversation locally about the time horizon and where community needs to see savings over time. We are very fortunate at the Blue Cross Blue Shield of North Carolina Foundation to have easy access to brainstorm with payers, both public and commercial, but it is challenging. And the question of scale makes it even harder, I will say, because community-rooted strategies are by definition local, and scaling regionally and statewide certainly presents challenges. Some of the partnerships I talked about are truly working in a few square city blocks in their first couple years. Now they're looking to spread into their cities or their towns, but partnering with payers and others to understand questions about scale and scope as well as ROI is an important part of this work. On the next slide, I'll just lead into this has impacted us, as I mentioned at the beginning, in ways we didn't envision. And that, I think, is proof that acting with intention in new ways can impact strategy at the organizational level on a much broader scale than we even anticipate. And so in detail on the next slide, we have basically had access to care, healthy living, and capacity building as our 3 priority areas for the first 15 years of the foundation. And today we're making changes to our strategy that reflect the learning of our grantees over the last 3 years to really, again, elevate equity as a core component, to prioritize policy and system change, to amplify community voice, and really center some of our funding priorities on these non-medical drivers, while acknowledging that health care, people in pain today need greater access to health care. And so certainly maintaining that emphasis, but also shifting our gaze a little bit further, we would say upstream. And in the next slide, briefly, we have named some areas of practice that are more consistent with these community-based determinants of health and social determinants of health. And that is, again, consistent with our learning over time. And that concludes my remarks. I can pause here for questions or take them at the end.